Welcome back to Anatomiqa. In this session, we will be discussing on the details of large intestine. The learning objectives of this session are state features, extent, peritoneal and visceral relations of large intestine, explain anatomical position, external and internal features, important peritoneal and other relations, blood supply, nerve supply, lymphatic drainage and applied aspects of cecum, explain anatomical position, external and internal features, important peritoneal and other relations, blood supply, nerve supply, lymphatic drainage, and applied aspects of appendix. List positions of vermiform appendix. The large intestine extends from the ileocecal junction in the right iliac fossa to the anus in the perineum. It is about 1.5 meters long. It is divided into the cecum, appendix, colon, which is further divided into ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. Rectum and anal canal will be considered in the sections on the pelvis and perineum. Large intestine is the most fixed part except appendix, transverse colon, and sigmoid colon, which are intraperitoneal and possess mesentries called mesoappendix, transverse mesocolon, and sigmoid mesocolon respectively. The primary function of the large intestine is the absorption of water and electrolytes, the storage and lubrication of undigested material until it can be expelled from the body as feces, synthesis of vitamin B complex and vitamin K by normal bacterial flora present in lumen, protection from invasion by microorganisms by its mucoid secretion, which is rich in IgA group of antibodies. Distinguishing features or characteristic features of large intestine are tinea coli, appendices epiploicae, and saculations or ostrations. Tinea coli are three ribbon-like bands formed by the aggregations of longitudinal muscle coats. Three bands are named as tinea libera, tinea mesocolica, and tinea aumentalis. Tinea libera is present on the anterior surface of colon except transverse colon. Tinea mesocolica is present on the posterior medial surface of colon except transverse colon. Tinea aumentalis is present on posterolateral surface except transverse colon. On the transverse colon, tinea libera is present on inferior surface, tinea mesocolica on the posterior surface, and tinea aumentalis on the antero-superior surface. Between the three tinea coli, the longitudinal muscle is present in thin sheets. Tinea are absent in appendix, rectum, and anal canal. Proximally, these three bands converge at the base of appendix. Distally, they unite to form two thick bands, anterior and posterior, which descend on the respective surfaces of the rectum. Tinea libera and aumentalis merge to form anterior band and passes in front of the rectum. Posterior band is continuation of tinea mesocolica and runs behind the rectum. Appendices epiploicae are small bags or pouches of visceral peritoneum containing fat attached to the tinea. They are present in entire large gut except cecum, appendix, and rectum. They are more numerous in transverse and sigmoid colon. They usually project between tinea libera and tinea mesocolica. Ostrations or saculations are present where tinea exist. They are a series of pouches or dilatations in the wall of cecum and colon between the tinea. They are produced because of tinea fall short of circular muscle coat in length. The saculations are responsible for characteristic puckered appearance of large intestine. Now let us go through each part of large intestine in detail. Cecum. The cecum is the part of large intestine that lies below the level of the junction of the ileum with large intestine. It is a blind-ended pouch that is situated in the right iliac fossa above the lateral half of inguinal ligament. Its surface projection occupies the triangular region limited by the right lateral plane medially, transtubercular plane above, and inguinal ligament below. Due to faulty rotation of midgut, the cecum may occupy any of the following abnormal positions: left iliac fossa, umbilical region, subhepatic region, right lumbar region in the pouch of Douglas. It is about 6 centimeters long and breadth is 7.5 centimeters. This is one of the organ in the body where the width is more than the length. It is completely covered with peritoneum. It possesses a considerable amount of mobility, although it does not have a mesentry. Attached to its posteromedial surface is the appendix. The presence of peritoneal folds in the vicinity of the cecum creates the superior ileocecal, the inferior ileocecal, and the retrocecal recesses. As in the colon, the longitudinal muscle is restricted to 3 flat bands, the tinea coli, which converge on the base of the appendix and provide for it a complete longitudinal muscle coat. The cecum is often distended with gas and can then be palpated through the anterior abdominal wall in the living patient. It communicates superiorly with ascending colon, medially at ileocecal junction with ileum, and posteromedially with appendix. The terminal part of the ileum enters the large intestine at the junction of the cecum with the ascending colon. The appendix communicates with the cavity of the cecum through an opening located below and behind the ileocecal opening. The cecum changes its shape and in position of attachment of appendix from birth. At birth, it is conical in shape and appendix is attached at its apex. Later, the cecal growth results in the formation of 2 saccules, one on either side of the anterior tinea coli. As the growth proceeds, right saccule grows more than the left, which pushes the apex of cecum and the base of appendix towards the left and nearer to ileocecal junction. As a result, the base of appendix is attached at the posteromedial wall of cecum. On the basis of growth, later, 4 types of cecum may be found in adults. Conical or fetal type, which is around 2%. Cecum is conical and appendix is attached at its tip. In infantile type, which is around 3%, cecum is quadrate in shape due to equal size of the right and left saccules, and appendix is attached at the depressed bottom between 2 saccules. Normal adult type, which is the most common, around 90%, the right saccule is larger than the left and the appendix is attached on the posteromedial aspect about 2 cm below the ileocecal junction. Exaggerated type, which is around 4 to 5%, the right saccule is immensely large and left saccule is absent. The appendix is attached just below the ileocecal junction. Coming to the peritoneal relations, in about 90% of cases, the cecum is almost completely surrounded by the peritoneum and has wide retrocecal recess, which may ascend up posterior to the lower part of the ascending colon and then called retrocolic recess. The appendix usually lies in the retrocecal recess. In 10% of cases, the upper part of its posterior surface is non-peritoneal and lies directly on fascia iliaca. The other recesses in the ileocecal region are superior ileocecal recess underneath the superior ileocecal fold and inferior ileocecal recess underneath inferior ileocecal fold. The superior ileocecal fold lies between the ileum and the ascending colon. It is a fold of peritoneum from the posterior abdominal wall raised by the anterior cecal artery. Therefore, it is called as vascular fold of cecum. It guards the superior ileocecal recess and opens downwards and to the left. The inferior ileocecal fold extends from the antero-inferior aspect of the terminal part of ileum to the cecum and appendix. It does not contain any blood vessels, hence also called as bloodless fold of Treves. It lies in front of the ileocecal recess, which looks downwards and to the left. Coming to the visceral relations, Anteriorly, cecum is related to coils of small intestine, sometimes part of the greater omentum and the anterior abdominal wall in the right iliac region. The cecum is reflected to show the posterior relations, the right psoas and the right iliacus muscles, the right femoral nerve, right genitofemoral nerve, right external iliac artery, right gonadal vessels, the right lateral cutaneous nerve of the thigh, retrocecal recess, often with appendix, forms the posterior relations. Above, it is continuous with ascending colon. Below, it rests on lateral off of inguinal ligament. Medially, the terminal part of ileum ending at ileocecal junction, vermiform appendix suspended by meso appendix, inferior ileocecal recess which is bounded in front by non-vascular fold called bloodless fold of Treves. Coming to the interior of cecum, it presents two orifices, ileocecal orifice and appendicular orifice. The ileocecal orifice is present on the posteromedial aspect of the ileocolic junction where ileum opens into large intestine. It corresponds with the intersection between transtubercular and right lateral planes. The orifice is 2.5 centimeters wide transversely. It is guarded by a valve called ileocecal valve. It is a rudimentary structure, consists of two horizontal folds of mucous membrane called lips that project around the orifice of the ileum. The upper lip is smaller, lies at the level of ileocolic junction. The lower lip is longer and concave upwards and lies at the level of ileocecal junction. The two lips meet at the ends and are continued as the mucous folds called cecal frenula, which may act as cecocolic sphincter. These are left or anterior frenulum and the right or posterior frenulum. Each lip is made of thickening of circular muscle coat covered by the submucosa and mucosa. The circular muscle of the lower end of ileum, called ileocecal sphincter, serves as a sphincter and controls the flow of contents from the ileum into the cecum and prevents regurgitation of contents of cecum into ileum. The smooth muscle tone is reflexly increased when the cecum is distended. The hormone gastrin, which is produced by the stomach, causes relaxation of the muscle tone. Appendicular orifice is a small circular opening situated about 2 centimeters below the ileocecal orifice, which is also slightly behind. Opening is guarded by semicircular mucous fold called valve of Gerlach, which is attached to the lower margin of the orifice. Coming to the blood supply, the cecum is supplied by the branches of ileocolic artery, a branch of the superior mesenteric artery. The ileocolic artery gives off anterior and posterior cecal arteries from its terminal part. The anterior branch reaches the cecum via the superior ileocecal fold. The posterior branch, in addition to cecum, supplies base of the appendix. The veins correspond to the arteries and drain into the ileocolic vein, then into the superior mesenteric vein, which finally drains into portal vein. Lymph vessels from cecum drain into ileocolic lymph nodes, which then drains into the superior mesenteric nodes, which belongs to pre-aortic group of lymph nodes. The cecum is supplied both by sympathetic and parasympathetic fibers. The preganglionic fibers from the sympathetic arise from 10th thoracic to 1st lumbar segments of spinal cord, relay in superior mesenteric plexus. The postganglionic fibers from superior mesenteric plexus supply the cecum. The parasympathetic fibers are derived from both left and right vagi nerves. Appendix. The appendix is a worm-like diverticulum which is narrow muscular tube containing large amount of lymphatic tissue. The appendix lies in the right iliac fossa and in relation to the anterior abdominal wall. It varies in length from 2 to 20 centimeters. It arises from posteromedial wall of cecum, 2 centimeter below the ileocecal junction. The diameter is 5 millimeters, which varies according to age. It is more in children than adults and often obliterated after mid-adult life. It is longer in children than in adults. The appendix presents 3 parts: base, body, and tip. The base is attached to the posteromedial surface of the cecum, about 2 centimeters below the ileocecal junction. All the 3 tenae converge to the base of the appendix. This fact serves as a guide to the surgeon to trace the appendix during appendectomy. On the surface, there are 2 methods to mark the base of the appendix. In the first method, draw a line from the right anterior superior iliac spine to the umbilicus. Mark a point at the junction of medial 2/3 and lateral 1/3 of the line which represents the base of appendix. This point is called McBurney's point, which indicates maximum tenderness in patients suffering from inflammation of appendix. The second method is draw transtubercular and right lateral or mid-clavicular planes. Mark a point about 2 centimeters below the intersection which represents the base of appendix. The remainder of the appendix is free. The body is narrow, tubular part. The tip is the least vascular, distal blind end. It is directed in various directions. It has a complete peritoneal covering which is attached to the mesentry of the small intestine by a short mesentry of its own called the meso appendix, which falls short of the length of appendix. The meso appendix contains the appendicular vessels and nerves. Body is kinked on itself where the free border of meso appendix ends and looks like a coiled worm. Hence, it is named vermiform appendix. Common positions of the tip of the appendix. The base of the appendix is fixed, but the tip of the appendix is subject to a considerable range of movement and may be found in the following positions, which are indicated by the R and of the clock. Paracolic or 11 o'clock position. The appendix passes upwards on the right side of the ascending colon in 2% of cases. In the retrocolic or retrocecal or 12 o'clock position, the appendix passes upwards behind the cecum and the ascending colon, which is the commonest position seen in 65% of cases. In splenic or 2 o'clock position, the appendix passes upwards and medially in front or behind the terminal part of ileum called pre-ileal and post-ileal positions respectively. The tip points to the spleen. The pre-ileal position is the most dangerous because inflammation from the appendix spreads into the general peritoneal cavity. The pre-ileal position occurs in 1% of cases and post-ileal position occurs in 0.4% of cases. Promontoric or 3 o'clock position. The appendix passes horizontally toward the sacral promontory, which is very rare and less than 5%. Pelvic or 4 o'clock position. The appendix descends downward and medially crosses the pelvic brim to enter the right side of true pelvis, which is seen in 31% of cases and is the second commonest position. In females, it may be related to right uterine tube. Mid-inguinal or 6 o'clock position. The appendix passes vertically downward below the cecum, called subcecal, and points towards the inguinal ligament and is seen in 2% of cases. Coming to the blood supply of appendix. The appendix is supplied by appendicular artery, a branch of the inferior division of ileocolic artery. The appendicular artery passes behind the terminal part of ileum, enters the meso appendix and runs in its free margin to reach the tips of appendix, which is the least vascular part. This artery is an end artery. When the meso appendix is short, the appendicular artery rests directly on the appendicular wall near the tip of appendix. It gives off branches through its course in meso appendix to supply the appendix. The venous drainage corresponds to the arteries. The appendicular vein drains into the ileocholic vein, which drains into the superior mesenteric vein and then into the portal vein. The lymphatic drainage. The lymph vessels drain into one or two appendicular nodes lying in the mesoappendix and then eventually into the ileocholic and superior mesenteric nodes. The nerve supply to the appendix. The appendix is supplied by the sympathetic and parasympathetic nerves. The sympathetic fibers are derived from 10th thoracic segment of spinal cord and parasympathetic derived from the right and left vagus nerves. These nerves pass through superior mesenteric plexus. From superior mesenteric plexus, the nerves arise and supply the appendix. Afferent nerve fibers concerned with the conduction of visceral pain from the appendix accompany the sympathetic nerves and enter the spinal cord at the level of the 10th thoracic segment. For this reason, the pain of appendicitis is referred to the umbilical region. Coming to another part of large intestine, ascending colon. The ascending colon lies in the right lower quadrant. It is about 5 inches or 13 centimeters long and 5 centimeters in caliber. It lies in the right paracolic gutter and extends upwards from the cecum to the inferior surface of right lobe of the liver, where it bends and turns to the left, forming the right colic flexure or hepatic flexure to become continuous with the transverse colon. The relations are, it is related to tinea coli and appendices epiploicae. The tinea libera is present on the anterior surface. Tinea mesocolica is related posteromedially and tinea omenthalis is related posterolaterally. Appendices epiploicae is present between tinea libera and tinea mesocolica. The peritoneum covers the front of and the sides of the ascending colon, binding it to the posterior abdominal wall. Posterior surface is non-peritoneal. Anteriorly, ascending colon is related to coils of small intestine, the greater omentum, and the anterior abdominal wall. The relations to the ascending colon posteriorly are the iliacus, the psoas, the quadratus lumborum, the transversus abdominis muscle, the iliohypogastric, the ilioinguinal nerve, lateral cutaneous nerve of thigh, the right fourth lumbar artery, and the lower pole of the right kidney. And that is the ascending colon in front of all these structures which are lying behind. Right colic flexure or hepatic flexure lies at the junction of ascending and transverse colon. In between the two parts of the colon, it bends forwards, downwards, and to the left. It lies in the right lumbar region, 2.5 centimeters below transpyloric plane and 10 centimeters to the right of median plane. It is covered with peritoneum. Anterosuperiorly, it is related to inferior surface of right lobe of liver, medially to second part of duodenum and fundus of gallbladder. Posteriorly, it is non-peritoneal and related to lower pole of right kidney. Transverse colon. The transverse colon is a U-shaped structure forming a downward loop about 20 inches or 50 centimeters long and extends across the abdomen, occupying the umbilical region. It begins at the right colic flexure below the right lobe of liver in right lumbar region and hangs downward, suspended by the transverse mesocolon from the pancreas. It then ascends to the left colic flexure between the spleen in the left hypochondriac region. The left colic flexure is higher than the right colic flexure and is suspended from the diaphragm by the phrenicocholic ligament. The lowest point of loop extends up to the level of umbilicus, but may sometimes extend into the pelvis. It is covered all over by the peritoneum except where tinea omenthalis and mesocolica are attached. Anteriorly, it is related to the greater omentum, and anterior abdominal wall. Posteriorly, it is related to the second part of duodenum, the head of pancreas, and the coils of small intestine. Superiorly, transverse colon is related to colic impression of liver, fundus and body of gallbladder, greater curvature of stomach, lateral end of spleen, and tail of pancreas. Inferiorly, it is related to coils of small intestine. Anteriorly, to layers of greater omentum and anterior abdominal wall. Behind or posteriorly, it is related to second part of duodenum, duodenojejunal flexure, head of pancreas, root of mesentry, and coils of jejunum. The transverse mesocolon or mesentry of the transverse colon suspends the transverse colon from the anterior border of pancreas. The mesentry is attached to the superior border of the transverse colon. The greater omentum, transverse colon, and transverse mesocolon forms a partition between the supracolic and infracolic compartments of greater sac. It forms a natural barrier against the spread of infections between the two compartments. Because of the length of the transverse mesocolon, the position of the transverse colon is extremely variable and may sometimes reach down as far as the pelvis. The contents of the transverse mesocolon are middle colic vessels, lymph nodes, lymphatics, and nerve plexuses embedded in loose areolar tissue containing variable amount of fat. The transverse mesocolon has two layers. Upper layer related to lesser sac, lower layer related to greater sac. Two borders, anterior border attached to posterior surface of transverse colon along tinea mesocolica, posterior border attached to anterior border of body and anterior surface of head of pancreas. Two surfaces, antero-superior and posterior-inferior surface. Antero-superior surface is related to the stomach and the lesser sac. Posterior-inferior surface is related to third and fourth parts of duodenum, duodenojejunal flexure, upper end of root of mesentry, coils of jejunum. Left colic flexure or splenic flexure lies at the junction of transverse colon and descending colon in left hypochondriac region, 2.5 centimeters above the transpyloric plane and 10 centimeters to the left side of midline. Here, the colon bends downwards and backwards, lies at higher level than right flexure, more acute and deep. The flexure is attached to the 11th rib in the mid-axillary line by a horizontal fold of peritoneum called phrenicocholic ligament. This ligament supports the spleen and forms the upper boundary of the left paracolic gutter. Coming to the relations, the left colic flexure is covered with the peritoneum. Superiorly, it is related to lateral end of spleen and tail of pancreas. Anteriorly, it is related to stomach and lesser sac. Posterior-medially to lower part of left kidney, posterior-laterally to the diaphragm. Coming to the descending colon, the descending colon is about 10 inches or 25 centimeters long and 3.5 centimeters in caliber. It is located in the left hypochondrium, left lumbar region, and left iliac fossa. It runs vertically downward in the left paracolic gutter from the left colic flexure to the iliac fossa. From the iliac crest, the distal part turns medially towards the pelvic brim, where it becomes continuous with the sigmoid colon. It is narrower and more deeply located than ascending colon. The relations are: the peritoneum covers the front and sides and binds it to the posterior abdominal wall. Anteriorly, descending colon is related to coils of small intestine, the greater omentum, and the anterior abdominal wall. Posteriorly, it is related to the lateral border of the left kidney, the left psoas, the left iliacus, the left quadratus lumborum, origin of the transversus abdominis muscle, the left iliohypogastric, the left ilioinguinal nerves, the left lateral cutaneous nerve of thigh, the left femoral nerve, left genitofemoral nerve, left fourth lumbar artery, and the left gonadal vessels. Coming to the sigmoid colon or pelvic colon. The sigmoid colon is about 15 inches or 37.5 centimeters long and 3.5 centimeters in breadth. It extends from lower end of descending colon at the left pelvic brim to the rectum at the level of third sacral vertebra. During its course, it forms a sinuous loop, hangs free in the lesser pelvis. The loop consists of three parts. First part runs vertically downwards along the left pelvic wall. Second part runs horizontally from the left to right between urinary bladder and rectum in male or uterus and rectum in female. The third part runs obliquely from right pelvic wall to rectosigmoid junction in front of third sacral vertebra. Coming to the visceral relations, first part laterally is related to left external iliac vessels, obturator nerve, sacral plexus, ovary and round ligament of uterus in females or vas deferens in males, posteriorly to left ureter, internal iliac vessels, lumbosacral trunk and sacroiliac joint, piriformis. Second part inferiorly is related to uterus in females or urinary bladder in males and superiorly by the coils of ileum. Third part is surrounded by coils of ileum. 5 cm above the rectosigmoid junction, the tinea libera and omentalis join to form anterior band. Tinea mesocolica continues as posterior band. Sigmoid mesocolon. Sigmoid colon is suspended from pelvic wall by a large peritoneal fold called sigmoid mesocolon. Hence, the sigmoid colon is intraperitoneal. The sigmoid mesocolon has an inverted V-shaped attachment called root of sigmoid mesocolon. It has left and right limbs. The left limb of the root is attached on the external iliac artery. It extends from the end of the descending colon to the bifurcation of common iliac artery. Here it turns sharply downward and to the right across the lesser pelvis, forming right limb extending from left sacroiliac joint to the third sacral vertebra attached on the pelvic surface of sacrum. The meeting point of the two limbs is called apex, situated in front of the bifurcation of left common iliac artery. Just lateral to the apex, a pocket-like extension of the peritoneal cavity passes upward posterior to the root of mesocolon, which is called intersigmoid recess. The left ureter lies behind this recess. The contents of the sigmoid mesocolon are sigmoid colon, sigmoid branches of the inferior mesenteric vessels and the marginal vessels of Drummond, branch of superior rectal vessels, lymphatics and nerves supplying sigmoid colon, loose areolar tissue and a layer of fat. Coming to the blood supply of the colon, the wall of large intestine. The colon is supplied by the branches of superior and inferior mesenteric arteries. The branches of superior mesenteric are ileocolic, right colic and middle colic branches. The branches of the inferior mesenteric are left colic, sigmoidal and superior rectal artery, which is the continuation of the inferior mesenteric. All these arteries form a circumferential anastomotic arterial channel extending from ileocecal junction to the rectosigmoid junction, close to the inner margin of colon, which is called as marginal artery of Drummond. The vasa recta arise from the marginal artery and supply the colon. Ileocolic supplies the lower smaller part of ascending colon. Right colic supplies the larger part of ascending colon. Middle colic supplies the right 2/3 of the transverse colon. Left colic artery supplies the left 1/3 of transverse colon and descending colon. Sigmoidal arteries supply sigmoid colon, and the superior rectal through its branch supplies sigmoid colon and the rectum. The veins draining the colon accompany the arteries. The ileocolic, right colic, and middle colic veins join the superior mesenteric vein, and the left colic, sigmoidal, and superior rectal veins drain into the inferior mesenteric vein. The superior and inferior mesenteric veins drain into the portal vein. Lymphatic drainage of the colon is important because of the carcinoma of colon. There are numerous colic lymph nodes which drain the lymph from the colon. They are arranged in 4 groups. Epiploic nodes are small nodules and lie on the wall of the colon. Paracolic nodes lie very close to the marginal artery along the mesenteric borders of colon. Intermediate colic nodes lie along the branches of the arteries. Pre-terminal nodes lie along the trunks of superior and inferior mesenteric arteries. Coming to the nerve supply of the large intestine, it is based on the development whether derived from the midgut or the hindgut. It is supplied by both sympathetic and parasympathetic nerves. Sympathetic fibers are derived from the preganglionic fibers arising from 10th thoracic to 2nd lumbar segments of spinal cord, relays in the celiac and mesenteric plexus. The postganglionic fibers arise from here and supply the large intestine. The parasympathetic supply has 2 parts. The parts from the cecum to the right 2/3 of transverse colon, which are derived from the midgut, are supplied by the right and left vagi nerves. They contribute fibers to celiac plexus. Without relaying, they accompany postganglionic sympathetic fibers, pass through Auerbach's and Meissner's plexus, and supply the gut. The parts from the left 1/3 of the transverse colon to the anal canal, which are derived from the hindgut, are supplied by the pelvic splanchnic nerves. The pelvic splanchnic nerves arise from cell bodies in the lateral horn of 2nd sacral to the 4th sacral segments of spinal cord. These fibers join inferior hypogastric plexus, pass through Auerbach's and Meissner's plexus, and supply the parts. The sympathetic fibers causes inhibition of gastrointestinal secretion and motor activity, and contraction of gastrointestinal sphincters and blood vessels of the gut. The afferent pain fibers accompany the sympathetic fibers. If they arise from midgut derivatives, it gives rise to periumbilical pain, but to hypogastric pain if it arises from the hindgut derivatives. The parasympathetic is motor and secretomotor to the gut and its glands. Till splenic flexure, it is vagus nerve. From splenic flexure, it is taken over by the pelvic splanchnic nerves. Sensory fibers are present in the vagus and pelvic splanchnic nerves. With this, we complete the gross anatomy of large intestine. Clinical anatomy of large intestine will be covered in a separate session. Thank you.